and where some of the gaps are, and then pass it along to Rhone, who's going to talk a little bit about what do we do with that in the clinical setting. So how far have we come? I'm going to talk about the evidence analysis library. The first release was 2007, and then it was re-released and updated in 2013. That's the evidence analysis library at the Academy of Nutrition and Dietetics that has an oncology section. And we will look at what the evidence tells us, and you'll see there are some big differences between 2007 and 2013. What are we doing after the evidence analysis library, kind of what's come out in the interim since then. And I will just highlight a few studies. Obviously, there are more than what I'm going to have time to highlight, but I will touch on a few things that are giving us some additional information about nutrition and outcomes. And then what's missing? What do we do next to fill in some of those gaps? So this is a study from 1980, which of course seems like a long, long time ago, but it was really a seminal or a landmark study, which is why I'm highlighting it. And the reason it's important is there are a couple of reasons. One is it was the very first time that someone really highlighted the issue of the potential for malnutrition to impact and have poor outcomes in cancer patients. So this is looking at weight loss versus no weight loss. And the weight loss is the light blue bar, and the no weight loss is the dark blue bar. And what you see here is in this large study looking at a little over 3,000 patients in the Eastern Cooperative Oncology group, basically just holding out, looking at weight loss and statistically controlling for things like tumor type and stage and age and gender and performance status, that when people lose weight, they have poorer outcomes. They have less survival. Those are weeks of survival on the y-axis. So clearly, weight loss is something that we need to pay attention to. Now, this doesn't prove cause and effect. It's just an observational study, but it really is a first look at, maybe this isn't such a good thing that patients lose weight. It may happen, but we probably should pay more attention to it. The other reason this is so important is 1980 is sort of a turning point for our care of oncology patients. That's around the time that we started treating patients mostly in an outpatient setting. Prior to the 80s, so in the 50s, 60s, and well into the 70s, we really treated everybody in an inpatient setting, which means they were a captive audience. They were able to be followed in the hospital, including with what they were eating and their performance status and all these other factors. But now that we've turned to treating nearly everybody outpatient, we've lost track of some of those parameters and what's happening to those patients because they're coming and going in and out of clinic. So the Evidence Analysis Library first released the Oncology Nutrition section in 2007. And as you can see, I'm just going to highlight a few key findings, is that when you look at some of these different tumor types, a lot of the evidence was considered weak. So looking at resting energy expenditure and chemotherapy, that was weak. Looking at oral arginine supplements, that was weak. Stem cell transplant, parenteral nutrition, the evidence is weak that there's benefit there. Radiation therapy and vitamin E, it's weak. Pancreatic cancer, the only thing we see is that at that point in time, the data suggested that omega-3 medical food supplements for cachexia, that it was strong that that wasn't necessarily going to be helpful. And that's going to change in 2013. Lung cancer, again, you can see we're weak on a lot of the things that we're looking at, chemotherapy and giving medical nutrition therapy. Is that a benefit? There just weren't enough studies to support that that was a benefit. Same with a lot of the hematologic malignancies. You see some fair looking at energy expenditure, protein needs. We note that glutamine doesn't seem to help post-stem cell transplant, but those are only fair. So we're still in the kind of in the weeds here with not really understanding what some of the good outcomes might be. Head and neck cancer, the only thing you see that's strong, and this is probably because, as we all know, head and neck cancer, those folks are very high risk nutritionally, is that medical nutrition therapy, pre-treatment evaluation, and then following up with those patients, there was strong evidence that that was helpful, and same thing for enteral nutrition. But other than that, again, we're talking weak and fair for most of the data, even for head and neck, which those folks tend to be the ones that would respond the best to nutrition intervention. Now you jump forward to 2013, and I'm not going to go through all of this table with you, but I wanted to highlight it to show you how nice and concise we have the data presented here. I really encourage anyone who has not taken a look at the EAL for oncology for the release in 2013 to take a look at it, because you can see here all the studies are highlighted. You can click on the study to go to that actual study, and it gives you pluses to show you that there was a finding for those particular outcomes. So it's an incredibly powerful look and overview at what we found in the interim. So we have a number of those tables. It's too big to even fit on one slide. But again, you can access this, and anyone who's a member of the Academy can look at it. Now, looking at some specific highlights, in 2013, this is where we start to see some real movement forward in an understanding, just in that interim between 2007 and 2013, is that screening and assessment, there are 4 recommended tools that are, the data are strong, that they're effective for helping us identify patients at risk of malnutrition. Rescreening and referral, there's a consensus statement, which means that all of the experts agree that referral to a dietitian is the best way to go for helping patients who are at nutrition risk when they are screened as being so. Medical nutrition therapy for adults, strong evidence that when that's delivered by a dietitian, you get better outcomes. Assessment, looking at diagnosis, staging, treatment, and tracking all of these things. Especially, I want to highlight nutrition-focused physical exam. There's a big movement to get dietitians more involved in looking at physical exam parameters. There's a consensus statement again from the experts that those are important things to do as you're following patients for their nutrition status. Adult oncology patients, this is where I said we get some change. In the 2007 guidelines, we showed that the evidence wasn't strong enough. There was sort of a strong finding that giving EPA or eicosapentaenoic acid containing medical food supplements wasn't particularly helpful. But in that interim, more data came out, and there is a strong statement that these things can actually help patients. Monitoring and evaluation for patients with cachexia, there's a consensus that that's very important in terms of helping patients do as well as they can. And that's important to note because, of course, cachexia can't be reversed with protein and calories alone. So we know that you can't just feed these patients, but having a dietitian involved is important in terms of maximizing what we can do for them. Looking at evaluating outcomes by an RDN, there's strong evidence that that should be part of the cancer care process. And there was a statement in these findings: poor nutrition status is associated with higher rates of hospital admission or readmission, increased length of hospital stay, lower quality of life and mortality, and decreased tolerance to treatment in adult oncology patients. So it was a very emphatic statement that if we have patients with poor nutrition status, they are absolutely going to do worse in terms of all of these outcomes that really matter to the patients, to the clinicians, to the families, anyone who's involved. Again, we're looking at grades 1, 2, 3, 4. These are how much evidence do we have, of course, grade 1 being the strongest. Poor nutrition status is associated with decreased tolerance. That's a grade 1 finding that, yes, if we have poor nutrition status, those radiation therapy patients are not going to do as well. Same thing for chemotherapy. We know that it's associated with increased length of hospital stay. That's a grade 1 finding as well. And that's important, of course, from a financial perspective because hospital stays are quite expensive. And if we can prevent that or minimize the risk of that, that's a positive outcome, not only for the patient, but also for the entire health system. Poor nutrition status gives lower quality of life. And I often hear people say, well, that's a soft outcome. But of course, if you're a patient living with that, it's not soft to you. And it's a really important finding is that if we let these patients degrade nutritionally, they really have a poor quality of life and they don't fare very well. And we know that it's actually associated with mortality. In other words, not addressing nutrition may contribute to those patients dying or dying sooner than they would otherwise. So what do we have and what do we need beyond the EAL? I'm just going to highlight, as I said, a few select studies that have come out in the interim. So there was a study looking at nearly 1,500 lung and GI oncology patients. And these authors did something interesting. They decided to build prediction models of length of life. So what we're talking about is prognosis. And nobody in the clinical setting will give you a prognosis that's, they're not going to sit down and say, you have exactly 6 months. But we do sort of look at patient populations and say, okay, how long might we expect those patients to live or have good outcomes? And they built 2 different models. They use conventional covariates. So most prognosis models look at tumor type, stage, age, and performance. Those are the 4 variables that are plugged into the model to give you an estimate of prognosis. And then they built a nutrition covariate model where they looked at body mass index, weight loss, and muscle index attenuation, meaning how well did they hang on to their lean body tissue. And what they found that was really fascinating is that the percent variability or the differences in survival that were predicted by the nutritional model versus the conventional covariate model. The nutritional model alone that included none of the conventional covariates predicted with over 90% accuracy the survival, whereas the conventional covariate was around 76% as far as predicting the variability in survival. So that was a really important finding, that nutrition is so powerful that it may even be more predictive of survival than some of these conventional factors that we look at. So again, we know that if we let malnutrition sort of get away from us, these patients really aren't going to do very well. And when we look at things like lean body mass and cancer treatment, this becomes very important. And sarcopenia, and that just simply means low lean body mass for your age and gender. So it doesn't have anything to do with necessarily body weight or BMI. We have plenty of folks who are obese and sarcopenic. We call it sarcopenic obesity, where they may actually look like they're fine, but they are really low in their lean tissue. And the reason that's important is because lean body mass tends to track better with outcomes than even body weight. So looking at lean body mass and outcomes, we see that regardless of their body mass index, they have poor functional status if they're sarcopenic, shorter time to tumor progression, shorter survival, higher incidence of dose-limiting toxicity, and it seems to alter the metabolism of cytotoxic agents. And that makes sense because lean tissue is very active in metabolism, and if you are very depleted in that, you may not process those drugs as would be expected. So you may end up underdosing or overdosing folks without even realizing it. So sarcopenia is a real problem. I call it a hidden problem because it's very easy to look at patients who have a high BMI, and you might say, well, their height, their weight, you look at their BMI, they look fine, maybe their BMI is 30, that puts them right on the edge of the obese category, but they very well may be sarcopenic anyway. We also know that this occurs in a wide range of BMIs. You get folks who are very low BMI and are sarcopenic, and you get folks who are very high BMI who are sarcopenic, and everywhere in between. And these are some percentages on what the presence of sarcopenia is in different populations. Advanced breast cancer, at least a quarter of patients tend to fall into this. Metastatic renal cell, about half of patients. And the interesting thing is in that population, about 40% of those patients are overweight and obese. So as you can see, it's easy to be fooled and say, well, that patient looks fine, but they're really not fine when you dig down and look at the different compartments of their tissue and what that looks like. Pancreatic cancer, no big surprise. About 60% are sarcopenic. We know that's a very hypermetabolic disease and patients really struggle. And interestingly, 16% of those folks were sarcopenic and obese. So again, we need to be careful to not assess folks just visually and assume that they're fine. And that gets back to that nutrition-focused physical exam that we're urging more dietitians to become proficient in, because that can help you uncover some of those differences between pure obesity, sarcopenic obesity, people who are a normal weight, have enough muscle mass, don't have enough muscle mass, all of those sorts of things. And we know that there's a significant prevalence among lung cancer patients and colorectal cancer patients who are more advanced. So looking at incidence of dose-limiting toxicity, it becomes clear when you look at all of these different agents and you look at different populations, colorectal, breast with a couple different therapies, lung and platinum regimens, renal cell, and you can see the normal versus the sarcopenic, and the percent of patients with dose-limiting toxicity is significantly higher in those folks that have sarcopenia. You can see those dark blue bars, and you look at 5-FU, and it's nearly 100% of those patients are going to have a dose-limiting toxicity if they don't have enough lean body mass to help them handle that drug. So that's a really important finding. And this is kind of a bright spot in the literature. This came out in 2012, and this is a randomized controlled trial, long-term follow-up of 111 patients with colorectal cancer. And the thing that's exciting about this is that it is randomized. It's not blinded, of course. I always point out it's hard to blind a nutrition intervention because people usually know whether they're getting special attention to their diet or not and what they're putting in their mouth. But it was randomized, which isn't always the case. We rely quite a bit on observational evidence. But this was a really nicely done trial. The follow-up was about 98%. There were hardly any patients that were lost to follow-up. And these folks were dedicated or were randomized to dedicated nutrition intervention or no special care, sort of what I call reactive nutrition care. In other words, they don't get attention unless they look like they're really struggling. So those are the kind of patients where you might get a call if you're a dietitian from your nursing staff and they'll say, hey, can you see Mr. Jones? He's lost 30 pounds, for example. Very reactive as opposed to proactive. And these folks were followed for 7+ years. The original findings on this came out in 2005, 7 years prior to 2012, showing that that intervention really helped with treatment outcomes. And at that point, of course, these folks were just post-treatment. So now this population has been followed for another 7 years, and we're looking at more long-term outcomes. And if you look at the first set of bars, adequate nutrition status maintained, what that's talking about is when you screen those folks as they go through treatment, how many of them actually screen as being malnourished and how many don't. And if you look at the intentional nutrition care, 91% of those folks maintained adequate nutritional status all the way through treatments, which means they never flagged as being malnourished. And you look at the usual care, 0%. That means every one of those patients at some point or another flagged as being at risk of malnutrition. Late radiotherapy toxicity, the differences are huge. 9% versus 65%. I often point out these are really unpleasant side effects, and if we can prevent those for patients' long-term well-being, this is the type of thing where months or years out, patients start getting adhesions in their gut, they get pain, they get alternating diarrhea and constipation, so it's a really life-altering event, and you have a huge reduction in that if you give those folks care during treatment. And then look at median survival, that's in the blue box. 4.9 years versus 7.3 years, huge difference. And again, remember, this is not folks who were followed with nutrition for 7 years. This is just taking advantage of that window of opportunity of keeping them well nourished during treatment. And you can see that has profound impacts down the line on how well they do. So what about null findings? I often point out that we are sometimes put it at a disadvantage in terms of findings that don't tell us that there's any benefit for medical nutrition therapy and interventions. But a lot of times when we look at those studies carefully, we see problems in the way the data were collected, we see problems in the way the intervention was given, was it standardized, who provided it? Oftentimes it's not a dietitian, so it's probably not going to have maximal impact. What did the population look like? Did the intervention start early enough? Again, I really stress proactive versus reactive nutrition care, big difference. And did the usual care group receive additional nutrition care that wasn't accounted for? That's often something that happens. And what about quality of life and financial impacts? Maybe you don't show a difference in their survival, for example, but you might show you saved a lot of money because they had fewer side effects, or maybe the patients just fared much better and had a much higher quality of life. And those kinds of things often aren't looked at. So obesity is prevalent in cancer populations, and this is another reason why we want to focus on getting those folks into nutrition care. It's very common, and it's very strongly associated with poorer survival. So if you look at the breast cancer, for example, where we have the most literature, 10% weight gain and just post-diagnosis is 2.7 hazard ratio for all-cause mortality, greater than 5% weight gain in the 2 years post-diagnosis, nearly 6 for a hazard ratio, so 6 times the risk of all-cause mortality. So not even just breast cancer, but dying of other things. And this is very similar. We see obesity very prevalent in lymphoma, childhood ALL. When you look at where people are at diagnosis, end of therapy, and 7 years post-treatment, up to a third of those folks are still going to be very overweight and obese. And prostate cancer, the survey that was conducted suggested that nearly half, or about 42%, are going to gain significant amounts of weight. ASCO has highlighted this issue. That's the American Society for Clinical Oncology, and they have a 4-point program that they're pushing as part of that position paper to say what they want to do about that. And you look at number 4, advocating for policy and systems change to address societal factors contributing to obesity, and here's the key, improve access to weight management services. This is something that we really want to focus on. And so some of our current realities, obesity at diagnosis and weight gain are common. Dietitian-led weight management programs do help, and we know they're more effective than non-dietitian-led programs or no program. And unfortunately, quality nutrition care for cancer survivors delivered by a registered dietitian nutritionist is very difficult to procure. That's a statement directly from the IOM workshop summary on the role of obesity in cancer survival and recurrence. So in summary, we know the data are quite strong that malnutrition adversely affects outcomes in many domains. The data are mixed on whether nutrition intervention changes that relationship between malnutrition and poor outcomes. And likely they're mixed because there just aren't enough data to see a strong pattern. And the data are relatively strong that failing to address long-term issues such as obesity and late effects will be problematic for the health outcomes of cancer survivors down the line. We're missing a big chunk with the financial data for the outpatient setting. We have quite a bit more for the inpatient setting, but we really need to focus on, what is our value for helping these patients not become malnourished, because we can see that they have fewer symptoms, fewer side effects, fewer adverse events, fewer dose reductions, fewer mistreatments, and all those things have financial impacts. So given the current state of evidence, what can we as dietitians do in your clinical practice now? What do you do in your clinic that can help sort of fill in these gaps and move us forward as a profession? So I am going to now hand the program over to Rhone Levin. Rhone has been a dietitian for 28 years, specializing in oncology for the last 17 years. She received her Bachelor of Science degree from the University of Wisconsin-Madison and her Master's in Health Education from Penn State University. Rhone is a past chair of the Oncology Nutrition Dietetic Practice Group and has served on the Evidence Analysis Library Work Group for Oncology. So Rhone was a part of all of those results I was talking about earlier. She is the chapter author on screening and assessment in the Clinical Guide for Oncology Nutrition, a co-author for the Complete Resource Kit for Oncology Nutrition, and co-author of the SOP, Standards of Practice and Standards of Professional Performance for Oncology Dietitians. Her passion is in creating patient access to oncology dietitians.
Rhone, are you there? Suzanne, I apologize. We may be having some trouble with Rhone's audio. Are you able to go through her slides until she's able to get those issues resolved? She's working on that right now.
Okay, no problem. Yeah, I can keep going. Okay, so, oh, go ahead.
Cancer treatment that has existed for the past couple decades.
Oh, there we go. She's back.
Okay, did you want me to start over?
Yes, please.
So starting on the first slide, this is just a quick review of where we are in current practice and how oncology patient. As an oncology dietitian, I have worked in several states over the past years and have witnessed oncology nutrition practices across the country. Many dietitians are working in stressful environments and without adequate resources. So what I want to talk about today is just how to best approach this situation. Next slide, please. Nutrition during cancer treatment that has existed for the past several decades is don't. In other words, malnutrition and weight loss have been considered to be an expected part of cancer treatment and worse yet, an acceptable effect of cancer treatment. In other words, in our oncology nutrition world, is that nutrition will be treated therapy to cancer treatment with the oncology nutrition professional embedded in the clinic setting. Several years ago during an ACCC, which is Association of Community Cancer Center webinar, how to develop oncology nutrition programming, Kim Jordan and Heidi Ganser, both members of our, reported a patient comment that has stuck with me for years. And the patient had said, it will tell them about nutrition services early in their treatment, which I think is a really powerful statement. Understand the value of nutrition services, the RDN of our services, but it's very common in the clinic that the administration and physicians and even what they're missing. So the big picture in an oncology clinic is of the oncology nutrition situation and how do you get their attention. So the decision makers, including administration, physicians, nurses who are in leadership, how do you educate them in these concepts behind proactive? This is the crash and burn consultation scenario, which we're also familiar with. Next slide, please. So this slide is oncology nutrition in the clinic. The first steps that we are implementing nutrition services is to create access to the high-risk diagnoses. And approach for setting up initial services, and so it's based for the high-risk diagnoses such as head and neck cancers, GI cancers, pancreas, and so on. But the fact is that malnutrition is often related to the ultimate cause of mortality types, and attempts to reverse severe depletion in all cancer types are generally unsuccessful. And you need to answer for your clinic is, how many other patients are not getting services? So you can document for them how many patients you're able to see, at what point you're able to see them, but we also need to be capturing that data of who is not being seen. Next slide, please. In current staffing practices, many cancer centers report that they offer access to nutrition care. And in this sense, we clearly need to better definition of what is considered adequate care. I just fell off my chair when I read that 99% of community cancer centers are considered to have adequate nutrition services simply because they have a referral to either a hospital dietitian or they have, 1 day a week for radiation treatment, things like that. So we need to define what is adequate nutrition. And in an example, this is an example of the 2013 PI Centers, which is reported by Colleen Gill, represents why having a cancer patients based solely on diagnosis leaves gaps in nutrition. And this, what this reveals is the system leads to inadequately focused nutrition time, surveilling patients, high-risk patients for the moment of decline instead of providing intervention that they need help. So again, virtually no time to address immediate concerns of all of the patients. Next slide, please. Current level of staffing or dietitian understaffing, we see a cycle of crash and burn nutrition. And everyone loses in this model. The dietitian cannot impact severe malnutrition. The patient has worse control or lack of cure from their disease. The suspected oncology controller care and finds the dietitian does not impact the nutrition status of the patients. And probably for the next patient. And drug companies or research environment may not see control or cure at the same rates as seen in clinical trials. So this is a situation that we're trying to change. Next slide, please. So what are the best goals for an oncology program? The #1 goal that we are working towards is to protect the treatment plan. Patients have better outcomes when they tolerate their treatment and don't have to dose reduce or break treatment. And the example I like to use is that 1% for every day of treatment break in head and neck radiation therapy, for every day there's a 1% decrease in control. And for many head and neck patients, they only start out with a 15% potential benefit from treatment. So every day is very significant. And we know in chemotherapy patients that about 85% of the planned chemotherapy is necessary to have been provided and received by the patient to achieve the best effect or outcome on control of disease or cure. And even in the setting of cachexia, when for many physicians and for many patients, the impression is that there isn't anything you can do to improve their nutrition, we know that about 40% of the cachectic effect can be ameliorated by behavior modification alone. Next slide, please. How can we work to implement these practices? How can we own performance improvement? And so my recommendation is on this slide, using validated nutrition screening tools, using malnutrition screening applied routinely throughout oncology treatment, timely referral, timely intervention, documentation including the malnutrition characteristics. I'm just going to touch on that briefly in a couple seconds, as well as standardized language and descriptors. And so numbers speak directly to administrators and to physicians. And this would be a recommendation for all of the dietitians out there, would be to prepare. And this is based off of the recommendations from the Oncology EAL, consistent oncology standardized approaches at your facility. So you would be developing your own practice, MNT, your own standards, and your own policies and procedures to become more effective. Next slide. Involves choosing your screening tool and your screening process. And I just please use validated tools when you are implementing screening or assessment. If you create your own, validating it. And this gives you, the position to stand, the most powerful data to stand upon when you are requesting or need additional services. So having validated information allows you to compare your numbers with other facilities as well as with published guidelines. According to the EAL, all patients should be screened for malnutrition risk on entry into oncology services, and rescreening should be repeated routinely throughout treatment to facilitate referral as needed. If referred to an RDN for evaluation, which may lead to the nutrition care process. So should be easy to use, standardized, rapid, non-invasive, and valid for the population, reliable, sensitive, and cost-effective. Next slide, please. And the example I like to use is from my own performance improvement. Actual data, which demonstrates the first year after implementation of evaluation at a community cancer center. And what we did is we captured in numbers and put it into a picture we're experiencing regarding access to oncology nutrition services. Of the by the validated tool for malnutrition, we were able to see approximately 40% of the patients were not being seen. And this clearly identified understaffing and from administration, which led to additional FTE. Next slide, please. When you are creating your oncology nutrition assessment, we do want to make sure that we are incorporating those characteristics for identifying and for documenting malnutrition. And this was accepted by the 2013 Oncology. This application of criteria is considered to be a framework to form your complete nutrition assessment. Next slide, please. And just taking a look at this, this is where we are moving from the kind of wishy-washy oncology, well, I shouldn't just say oncology, but nutrition practices for identifying problems into actual concrete measures that we can collect outcomes from. So using this type of approach in your nutrition assessment moves you forward in your clinic. What I have is that as you are looking at doing more of this data collection and patient to consider so identifying what education and training you need to feel comfortable moving forward and you need. So this means discussing with your manager to get the items and the training into the facility. I just finished working at, we put it into the dynamometers for hand grip strength measurement. And then thirdly, develop and implement the processes and procedures to get them into your clinic. Expect, you're talking about using resources and assigning resources. So be prepared, needs to be done. And then finally, fostering and creating that culture of the people in the clinic, all of the clinicians, the nurses, but as well as the radiation therapists, that everyone feels comfortable talking about nutrition and referring for nutrition. Next. The oncology nutrition assessment, just briefly, what we want to do is we're practicing proactive nutrition versus reactive nutrition, which is, of course, more effective to the patient, but it's for the dietitian. And this is a key point, again, to share with your decision. The oncology nutrition assessment takes into account several unique and potentially complicating considerations as documented on this slide, including the hallmark nutrition assessment and thought process, which is we are always thinking what comes next for the patient's treatment. So we're preparing for that patient for anticipated or impact symptoms. So again, this is something to share with the staff about what it is that we do that's different than just, for example, having a nurse assigned to give a handout to a patient when they're experiencing a complication. This is just, talking about the impact about documenting, capturing and documenting this information about their nutrition impact symptoms. So these symptoms, of course, develop and change rapidly during each treatment cycle, and they need to be assessed at each contact. I mean each dietitian contact. I mean each professional contact. So each documentation is to include the presence of, but as well as again, we're thinking ahead and saying what's coming next, and so it's important to document or the lack of nutrition impact symptoms that we were in. Next slide, please. And of note, since very little time is currently allocated to important issues of treatment, survivorship nutrition, which may assist in preventing recurrent cancers, don't forget to document the need for this important service as well and count how many patients credit from the service. I know a lot of clinics currently are doing survivorship practitioner and through social workers and not including a dietitian. So we're providing nutrition information. So once again, really important to make sure that we are counting referrals or appropriate referrals that would have been important for those patients. Slide, please. And then just kind of finishing up this concept of our nutrition, making sure you're using standardized language to consistently evaluate and document nutrition impact symptoms. This is one example of the CTC, which is the Common Toxicity Criteria, which is a standardized approach to measure, rate, or grade the effects of treatment and patient tolerance. It's not perfect for nutrition. Dietitians will often use additional terminology, but this is important to find out what your facility is using and then implement them into your documentation as well. So building these into your nutrition assessment and using the same language as the oncology team makes you more relevant to the team. Next slide, please. And then lastly, capture oncology nutrition outcomes in research and find out what research is occurring at your facility. Make yourself available as a resource to the IRB. Get trained for the IRB so that you can participate on relevant research. And make sure that educate the researchers in your facility, whether it's nurses or physicians, regarding the concepts behind this oncology nutrition so that they are not missing a piece of the puzzle in the research plan. If they're not accounting for sarcopenia, for example, if they're not accounting for weight loss and intolerance to treatment, even if we have a quote-unquote cure for cancer or good treatment that comes out of the research, if the patient is not able to get the treatment, then they aren't going to get the benefit. Last slide for me, please. And so, you know, thinking of that T-shirt that's around right now, keep calm and carry on. So please don't give up. We are working towards a perfect world one step at a time, and it's frustrating and it's slow, but there has been movement. There is hope for the future to create patient care that is effective and provide oncology nutrition services at the right level, at the right time to meet nutrition needs. And offer oncology nutrition services at a standardized quality to all patients. So how do we move forward? So next I'd like to introduce Elaine Trujillo. Elaine is a nutritionist at the National Cancer Institute, National Institutes of Health, where she promotes translation of information about bioactive food components as modifiers of cancer and collaborates with other federal agencies, such as serving on the management team for the 2015 Dietary Guidelines for Americans. Elaine is the project manager for the benchmarking committee and a past chair of the ONDPG. At the state level, she has served as chair of the Education and Research Division for the Maryland Academy of Nutrition and Dietetics. Ms. Trujillo holds a Bachelor of Science from the University of Delaware and a Master of Science degree from Texas Women's University. Ms. Trujillo uses a variety of approaches to share her views and findings about nutrition and other interested in health, including peer-reviewed journal publications, book chapters, and her most recent publication, The Calories In, Calories Out Cookbook, which focuses on healthy recipes and energy expenditure. Elaine?
Great, thank you, Rhone. Thank you so much. You all, I'm hoping you can hear me. I'm going to go ahead and get started. I do have to first say that I'm a federal employee, so what I'm talking about today are my opinions and not the opinions of the NCI or the NIH. So I think we've learned a lot from Suzanne that there's evidence to support that nutritional status of the cancer patient affects morbidity and mortality, and that maybe nutritional interventions improve outcomes. And we learned from Rhone that we are not delivering optimal nutrition care to our patients. So I'm going to focus on what are we going to do about it. So I want to step back and look at this schema that was developed by the ONDPG. For those of you who are not aware, ONDPG is the Oncology Nutrition Dietetic Practice Group. And this was developed more than a decade ago and published in 2008. It was really developed as a roadmap to optimize the delivery of quality nutrition care. And it starts with the nutrition care process and model in the center and then branches out. So the ONDPG has been working for many years, and in 2006, you can see here, standards of practice and professional performance were published in our Academy Journal. In 2007, the evidence analysis library questions and practice guidelines were completed. In fact, our group, Oncology Nutrition, was the first DPG to join the Academy's analysis team to develop these questions, and it turned into the largest evidence analysis project from the Academy. In 2008, board certification in oncology nutrition was created. In 2013, more questions were answered in the evidence analysis library, and the practice guidelines were updated. And through the years, outcomes research continued, and member education materials were developed to assist members in providing optimal quality nutrition care. So the purpose of sharing this roadmap is not to highlight the accomplishments of the ONDPG, but is to give you a broader understanding of the pieces that were put in place to ensure the delivery of quality nutrition care so that we could ultimately accomplish the top goal, the bar up top, which is to deliver oncology medical nutrition therapy as a routine component of comprehensive care. So in measurable terms, it is the provision of adequate staffing and reimbursement. And so this is the piece that remains undone and we hope to accomplish. So that last piece of the roadmap was critical, and it was tied to the overall vision and goal of the ONDPG then and today, which in simple terms is to work towards a day when every cancer patient has access to nutritional care. So the problem of access to nutritional care is the reason for me speaking today. We think it is a problem for the majority of cancer patients. And honestly, we don't have a good handle on it. We don't have much data. We have some data from surveys. I'm going to skip the first survey here because that's a European survey from Iceland, and I want to focus on the US. The other survey up here, the survey by Platic and colleagues, was a cross-sectional pilot study of comprehensive cancer centers. And so out of 40 centers contacted, 32 completed the survey. So there was an 80% response rate. So it's a small study, but a good response rate. And 30 of the 32 centers, or 94%, offered referral or consult-based services with an RD. So what does that exactly mean? The authors describe that referral or consult-based service implies that a clinical nutrition professional consults with the patient as a result of referral from another healthcare professional or self-referral. There is no assurance that the patient needing clinical nutrition intervention will be referred, and if a patient is referred, there's no assurance that a patient will end up receiving any nutritional services. So my interpretation is that it means that the cancer center has access to inpatient nutrition services, and thereby they feel assured that nutrition services are covered, even though they do not include nutrition services as part of their multidisciplinary team. So 94% offering coverage sounds impressive, but if you delve into what that actually means, in my opinion, it's misleading. So this was a small survey and sampling of what is going on, and this survey did not examine what is happening in community oncology centers and not in the cancer treatment centers of America. So I would stress that more data is definitely needed. And as Suzanne alluded to earlier, from this 2012 IOM report on the role of obesity in cancer survival and recurrence, quality nutrition care for cancer survivors delivered by dietitians is difficult to procure. So data I found in 2009 in a report evaluating staffing models suggests that nutritionist staffing of 1/2 full-time equivalent in inpatient cancer centers and 0.2 full-time equivalents for chemotherapy and radiation areas, or outpatient areas. So this is pretty dismal. And again, it is just a sampling, but it rings true to dietitians in the trenches. These numbers sound about right for what is happening in cancer centers. So the bottom line is that the majority of patients in outpatient centers don't have access to nutrition services. So in order to deal with the problem of access to nutrition care, in 2012, the ONDPG approached it from the angle of staffing. How do we improve staffing in the outpatient cancer center so that more patients have access to care? At an executive committee meeting, we brainstormed some ideas. Those ideas included maybe doing more national studies, publishing papers, looking at electronic medical records, and other ideas. And we realized that most of our ideas would not have an outreach beyond our own colleagues. So we discussed various directions, and we knew that we needed a big impact and one that would go beyond us. We had a light bulb moment and that was to reach out to the Institute of Medicine, knowing that their impact is far-reaching and worthy of policymaking. So in 2013, we held our executive committee meeting in DC, and we invited members of the Food and Nutrition Board of the Institute of Medicine and Yaktine and a colleague of hers to join us. And so at that meeting, we discussed the problem of access to nutritional care. They were not aware of the problem. They were intrigued, and they were honest with us. They felt that if they were not aware of this problem, it was likely that others in the medical, healthcare, and science community were also not aware. They suggested that the first thing that needs to happen was a workshop to bring awareness to the problem. A workshop on the topic of access to nutrition care in outpatient cancer centers could get the attention of the healthcare community, scientists, insurance carriers, healthcare administrators, legislators, and the public. So the IOM was on board, and in 2014, at another executive committee meeting, a benchmarking committee was formed within the ONDPG, and the first task of this committee was to write a proposal. So this is the highlight here. I mean, I am happy to report that in 2015, the IOM received governing board approval to move forward with the workshop. You can see the title there. It's quite a mouthful, but I think it captures the essence of what the workshop will cover. The official launch date is September 1st, so that's passed. We have launched, or I should say IOM has launched, and that is when the process of beginning the workshop activities begin. The actual workshop will happen in early 2016. It will take place in Washington, D.C., and will also be open access through webinar. So we can get the word out to medical and science professionals and all those others I mentioned, healthcare administrators, insurers, legislators, and public advocates. It will be a one-day workshop, and it will be interactive. So I'm happy to report that the workshop is launched. There's still more to do, and the IOM and the ONDPG is still looking for support. So here are the key issues. These are the issues that are outlined in the proposal and that will be addressed in the workshop. And I'll go through each one of these in the next few slides. I would encourage, if you have not read it, to look at the full proposal. It is on our website. I encourage you to download it, to read it, and share it with your colleagues. So we need to examine if clear standards for nutritional screening and intervention are needed in outpatient cancer centers. As we know, most oncology care is delivered in outpatient centers. The Joint Commission mandates that inpatient nutrition screening occur within 24 hours of admission. There are ambulatory care standards for nutrition screening, but they are ambiguous and leave room for interpretation. The second area is we need to examine if the evidence of nutritional status and nutritional interventions impact morbidity and mortality. We need to determine if the current evidence is robust enough, are more studies needed, and how much is enough to change policy. We need to determine the access to nutrition care in outpatient centers. We don't have a handle on that, as I mentioned earlier. What are the current dietitian to patient staffing ratios, and what are optimal staffing levels needed to improve health outcomes of cancer patients? We need to look at costs. Money talks, as we know, and we know that malnutrition and obesity are associated with increased costs, but few studies have actually directly examined cost effectiveness of nutritional interventions. So those are the four key areas, but I encourage you to take a look at the proposal. Other issues such as the concern over the use of dietary supplements in cancer populations, obesity, weight gain during and after treatment, and other issues are included in the proposal and worthy of your attention. So while there is still lots to do, there is light at the end of the tunnel. The workshop is a first step. It would likely bring awareness to the problem of nutrition access and bring various stakeholders together to discuss how to move forward. Maybe discussions will revolve around the need for more research, how to best do that, or maybe there are enough studies and we need to look at other things like electronic medical records, for example, to determine if nutritional interventions impact costs. We don't know what the discussions will entail yet. The workshop will likely bring up these issues that need further examination. So this one-day workshop will likely not be the end of the discussion or solve all the problems, but will be the beginning of discussions and the start of potential solutions, so that we can foresee a day when every cancer patient has access to nutritional care. So I want to thank these fine ladies who make up the ONDPG Benchmarking Committee, and Ann Yaktine in the center, who is the director of the Food and Nutrition Board at the IOM and our champion. I also want to thank Tricia Cox, who's chair of the ONDPG, Andrea Wynn, past chair, and Calais Trentham, chair-elect, for their support. I want to thank our generous sponsors, in particular the American Institute for Cancer Research, who is our largest sponsor. We also appreciate the support of the ONDPG, Alcresta, the National Cancer Institute and the Office of Dietary Supplements at the NIH, the Academy and the Academy Foundation, the American Cancer Society, Quorum CVS, Option Care, Clinical Nutrition Management DPG, Medtrition, and the Annie Appleseed Project. And I also want to thank ONDPG members and anyone else who has donated through the Oncology Nutrition website, which is still open, by the way. So I want to thank you for tuning in today. At this point, it is my pleasure to introduce you to Dr. Ann Yaktine. Ann is the director of the Food and Nutrition Board of the National Academies of Sciences, Engineering, and Medicine. She is a 2008 recipient of the Institute of Medicine Cecil Award. In 2009, she participated in the Korea U.S. Symposium on the Science of Food Safety Assessment. She has published journal reports on nutrition and cancer, nutrients and contaminants in food and nutrition assistance programs. Dr. Yaktine is a member of the Academy of Nutrition and Dietetics and the American Society for Nutrition. She holds a master's degree in nutrition from the University of Kansas and a PhD in biochemistry and cancer biology from the Epley Institute for Research in Cancer and Allied Diseases at the University of Nebraska Medical Center. So I'm going to pass on to you, Ann.
Thank you very much, Elaine. And I too will open with a disclosure that my remarks today reflect my opinions and not those of the National Academies of Sciences, Engineering, and Medicine. I also want to acknowledge the work of the ONDPG, all that they have done to bring this to bear, and express how much I look forward to working with you on this project. Let's see if I can advance the slides. I seem not to be able to advance the slides. Let's see if this works.
Okay, and I can go ahead and advance them for you if you'd like.
Okay, so let's look at the next slide, please. So what I want to do today is basically talk to you about the role of the IOM and what we can do to further the goals and objectives that the members of the ONDPG have expressed to you today. I'll do that by talking about who we are and how we work, give you some examples of our activities and our impact, and then we'll open up for questions. So if we can have the next slide, please. The Institute of Medicine dates back to the 1970s. It is the health arm of the National Academy of Sciences, Engineering, and Medicine. We are a private, independent, and nonprofit organization that works outside of government, although we were initially chartered through an act of Congress that took place in 1863 in the Lincoln administration. I want to mention that the IOM has recently undergone structural reorganization, and so now we are a division under the National Research Council, and the former IOM membership component of the organization has moved to join the National Academy of Sciences and National Academy of Engineering as the National Academy of Medicine. All that's quite confusing, so we're going to leave it at that, and for our purposes today, we'll refer to us as the IOM. So in the next slide, you can see that there are 7 boards in this division. The Food Nutrition Board is one of them. The Food Nutrition Board has been around since the 1940s, when we were called upon by the government to issue recommendations for nutrient standards for the health of all Americans. They were actually initially used to improve the health of recruits in World War II. And from there, we went on to expand our work. If I can have the next slide. We serve, the IOM in general serves as an advisor to the nation to improve the nation's health, giving unbiased and authoritative advice. And I want to emphasize evidence-based recommendations. We do this through committees that are composed of experts who we vet to avoid conflicts of interest, particularly financial conflicts. Our committee workers, our committee members, work pro bono. They are volunteers and give their time freely, and they give a lot of time, I have to say, to make our workshops and consensus studies come together. The important point that I want to make about the IOM is that this is a neutral venue for open dialogue and discussion. And I think that that venue is what makes IOM products valued across the country and across the world, and also it has a tremendous reflection of our impact. Many of the activities that we perform include consensus studies. These are studies that result in recommendations to a stakeholder or to the government calling for action. And I'll share with you in just a few minutes some examples of how that works. In this case, with the ONDPG, the activity is a workshop. Our workshops do not have recommendations. However, they do produce products that include a summary report that captures not just the presentations, but the essence of the discussions. And that's an important point to make, because it is those discussions that move the ball forward towards consensus studies and other activities that result in policy change. We also hold other activities, forums, and roundtables, and these are broad discussion groups. If I can have the next slide, please. How we fit into the regulatory process. Consensus committees are convened to weigh the evidence on specific policy questions or other questions posed by the sponsors. And as I mentioned, they do result in a published report with recommendations. These committee recommendations are made only as advisory. So in other words, we do not issue regulations. However, it's fair to say that our recommendations are very often taken completely or very nearly completely. And I'll just slip in an example here. We review the nutrition assistance programs for the USDA for the school lunch program and the child adult care food program. Upwards of 95% of the recommendations made became official regulations in those programs. So we can be very effective in that regard. Our study sponsors, if we can go back to the previous slide, our study sponsors decide whether or not to implement the recommendations, but I want to emphasize here that the sponsors do not determine what those recommendations are, and I think that's one of the value-added components of an IOM activity, is that the sponsors pose the questions and ask for the work, but are not direct participants in it. Next slide. So how an IOM workshop contributes to policy questions. It begins with a planning committee. The planning committee are a set of experts that are taken from nominations from various stakeholders. These experts represent the best and the brightest in the field, and they help plan the presentations and discussions. They elucidate the problems and progress on policy or technology issues in their planning process, and they identify those individuals who can best represent the goals and objectives of the workshop to present their data and engage participants in a fruitful and active discussion. At the end of the workshop, a report is issued, as I mentioned before, summarizing the proceedings, but no recommendations are made. So in the next slide, we'll take a closer look at the Food Nutrition Board. So the FNB is the focal point for activities of the IOM that concern food, nutrition, and food safety, and their roles in health maintenance and disease prevention. Next slide, please. And at the present time, we are engaged in the activities that you see before us. We are reviewing the WIC food packages for the U.S. Department of Agriculture. We have a consensus study addressing issues related to food allergies. We have another consensus study examining national, state, and local prevalence and trends in obesity. These will all result in reports with recommendations to the U.S. government and to stakeholders. We have an ongoing workshop that will actually take place at the end of October on meeting the dietary needs of older adults. We have a food forum, which is a forum that brings together a range of stakeholders from government, industry, and consumer groups to talk about issues of mutual concern. And a roundtable on obesity solutions, which has a similar goal with stakeholders from the obesity community. Next slide, please. I think it's fair to say that the IOM, the National Academies, and the Food Nutrition Board have had very significant impact on moving policy forward. And for example, we had a project that was convened several years ago now called The Weight of the Nation. This culminated in a documentary film series that subsequently garnered nomination for an Emmy Award in the documentary category. The Weight of the Nation has been disseminated across the country down to the level of actual schools and community projects at that level, as well as having impact at the national level. We issued a report in 2007 on competitive foods that are sold and brought into schools, asking for recommendations to reduce the numbers of sugar-sweetened and high-fat and high-sodium foods that are brought into schools. And to that end, one of the success stories is that Dannon Company has pledged by next year to reduce the total sugars in all of its children's yogurt products to meet the recommendations in this report. In the next slide. AAP has endorsed the recommendations made for the dietary reference intakes for calcium and vitamin D, and this endorsement will apply for the next 5 years unless that report is retired or revised by the IOM. One of the biggest impacts we've had is the impact of the weight gain during pregnancy report. The American College of Obstetrics and Gynecology has adopted those recommendations and disseminated them amongst their members, and as well has included these recommendations in continuing education units for physicians. Next slide, please. We're probably best known for the dietary reference intakes. These are the nutrition standards that reach far into the work of dietitians. They underpin many national policy initiatives, including the dietary guidelines. So these are very important products that we produce. In the next slide, you can see some of the uses and applications for the dietary reference intake. This is an infographic that is available. You can download it for free at our website. The website is in tiny letters at the bottom of one of the bottom on the right-hand side, and it's also available. The website I'll note at the end of the presentation. So next slide, please. So in terms of the standardized nutritional care in cancer, outpatient cancer centers, the role of the IOM here is to ensure the quality, integrity of its products by, as I had mentioned previously, enlisting the best and the brightest amongst scientists, health professionals, and other experts to address the scientific and technical questions posed by this project, by maintaining independence from external stakeholders, by staying relevant. We produce 200 to 300, not the FNB, but the IOM in general, produces 200 to 300 authoritative reports a year. And as I had mentioned just prior to this, that many of these have had long-reaching impact. And in the last slide, I want to thank you. And again, here is our web address. If you go there, you can see all the projects we have ongoing, and you can download materials. The products of the workshop that we're working on with the ONDPG will also be made available through this website. Thank you very much, and we'll go to questions.
All right, thank you very much to all of the speakers. I am going to unmute all of the participants at this time, so if anyone listening does have any questions, please ask, and our speakers will do their best to answer. Okay, I did not seem like we have any questions. So again, thank you very much to our 4 speakers today. For those of you that did join late, we were able to record this entire presentation, and we will have it up on our DPG website by the end of the month. Thank you again to everyone.
And I am in the planning phases of an oncology nutrition practice-based research outcome study. It was initiated by Tricia Cox from the ONCDPG, and we are also collaborating with the Academy's Council on Research to put this project together. And so my question for the speakers, I do want to thank you all for this great presentation, which has been a lot of useful background information. But I'd like to ask you, what's the #1 most important question that we can answer in the field of oncology outcomes and dietetics practice?
Great question. I don't know, are any of the speakers able to speak to that?
Hi.
Sure. Well, go ahead.
I was just going to say about in the EAL, the focus that we created for the 2013 EAL. And if you remember the original EAL, which was done in 2008, they answered something like 78 questions. And then because of financial constraints, we were only able to answer 11. We focused on the question, how do we prove that the dietitian makes a difference?
Thanks, Rhone. So yeah, that's our overarching goal with this project, is finding out how the dietitian makes a difference. I know from Elaine's presentation, there are also, I look forward to reading the rest of that proposal, but staffing levels and access, I think, are other important questions we can get to.
Yeah. I will.
Hi.
This is Suzanne Dixon talking. Yeah, I think that you kind of have 2 overlapping goals, which is one is to determine what are adequate staffing levels in the cancer center where we can actually have patients get the care they need. That's one big question is, we don't really have a handle on how many RDs do we need. And then the second piece of that is part of the reason why we are so understaffed is, of course, that we don't have the financial data that would underpin getting solid reimbursement across the board. So I feel that proving the worth of the RD, what it really ties into, besides, of course, patient outcomes, is do those better outcomes translate into money saved, better overall outcomes for the entire financial of the healthcare institution, all of those things, because I think we all struggle every day with this issue of we can't really bill people very easily. And if you charge patients, a lot of times they won't opt to come in and see you because they don't want to pay out of pocket. So those two pieces of what level of staffing do we need and knowing what level of staffing do we need, how do we get there? Because we need to show that it's worth financial sense for the institutions to hire those individuals.
Well, we have in the department here recently conducted by Rosa Hand and the Practice-Based Research Network a study on staffing. So I think we've got some solid methods defined for that. And in our work on validating the malnutrition clinical characteristics, we've also built some good methods for getting at that cost-effectiveness data, which is very difficult. If there was, what would you say is the lowest hanging fruit for something, a specific cancer or treatment that we could target with dietitians to find that financial difference?
Well, for me, one thing that I hone in on is trying to look at the highest risk populations. You often see the biggest differences in patient populations such as head and neck cancer, pancreatic cancer, lung cancer. So looking at those patients that we know for a fact from our clinical expertise that if they don't get access to a dietitian, they do incredibly poorly. And so kind of the low-hanging fruit in my mind would be to focus on some of those patient populations that really are at just incredibly high risk of malnutrition and showing that difference that if they do get that care, a lot of that risk is ameliorated. And I would welcome any of the other speakers to chime in on that.
This is Amy. I know technically I'm not a speaker, but I'm working here in the trenches directly in patient care, and I would second that. Head and neck, without a doubt, would be the first group that I think it would be, quote unquote, the lowest hanging fruit, because virtually every one of those patients develops some degree of malnutrition during treatment.
And this is Elaine. I would just chime in that, an ideal study would compare usual care, what's going on now, which are no standards in the clinics, versus clinics that put standards in place, and this is the important part, adhere to them. So screening happens, nutrition risk factors identified, intervention happens, and compare those populations. That would be ideal.
Oh, that's great. So we could cluster perhaps by protocols at the different centers, because we'll be targeting getting dietitians from the entire practice group from many different types of centers with different protocols.
And I think what Elaine just said gets at something that I just mentioned briefly when I was presenting, is that the difference between reactive nutrition versus proactive, just whether or not people are being identified from the moment they walk in the door and followed up systematically versus they're simply referred when they, as Rhone says, crash and burn, which is very common. I think reactive nutrition is pretty much the standard right now.
That's what I practice, correct, is reactive nutrition. Yes.
Exactly. Every single one of us who's worked in cancer centers can tell you the horror stories of, can you see Mr. Jones? He's lost 40 pounds. And of course you think to yourself, you probably should have seen that person 35 pounds ago. So just that is, as Elaine alluded to, is making sure that not just that people have a protocol in the books, but that it's actually being followed so you can see those differences.
Good point. Make sure we're checking how they're following those protocols.
As Elaine said, on paper in some of those studies, it can look like, you've got, 97% of centers reporting that they have access to nutrition care. And of course, then when you dig what that means, it means absolutely nothing. It means that patients, if they're lucky, maybe get a referral to an inpatient dietitian who's probably too busy to see them anyway.
We've actually got some exciting new methods for answering that question of our protocols and our guidelines being followed. We've developed them for a study we're doing with the diabetes practice group on the new prevention of diabetes practice guidelines, where we collected data using ANDI, which is our health and research informatics infrastructure. And by doing that, we get data not just on the patient parameters, but also on the nutrition diagnosis and the intervention and the follow-up. And we can compare that to predefined standards of what the care should look like if it's following protocols and guidelines, and get an objective measure of protocol adherence. So I think that would be useful here too.
Just as a final comment, the protocol adherence piece, in a diabetes setting, it actually may be a little easier for you to assess that because in outpatient, there are some mandates in place for the number of visits that a patient will have access to a dietitian after a new diagnosis. And so we know that those folks actually do get reimbursement. So the likelihood their protocols are being followed is probably much higher than the oncology setting.
Yeah. One more, if I can, especially for Rhone, when you were doing the EAL guideline where you felt like there should have been good evidence because you know nutrition is working there, but you just couldn't find it. So I guess the opposite of low-hanging fruit. But what are those areas where the evidence is really lacking that perhaps we could find something?
Well, probably the biggest glaring missing piece of the puzzle in terms of the research was that it was not clear whether or not an RDN had been involved in the research, or in terms of the intervention. So a lot of the materials that are available or had been available throughout the world, it wasn't clear who actually did the nutrition intervention, so it was hard to say that a dietitian made a difference versus just nutrition care. So that would be probably one thing that would be important for us to be, I guess, modifying in future research.
Great. That is something we can definitely do.
And that's, this is Suzanne again. I mentioned that, I alluded to the fact that there are a lot of negative or null findings in the research.
I saw a few people raise their hands.
And a lot of times when you look at those studies and you kind of pick them apart, you realize that the intervention wasn't actually delivered by a dietitian, and you think.
And thank you to all of the speakers.